Good morning.
Okay, sorry for the inconvenience. I will be talking on updates on management of hypertension. I will be looking on the evidences behind the 2020 International Society of Hypertension and Europeans and American guidelines. So when you see the epidemiology of hypertension, hypertension is a dominant contributor to global mortality. By 2010, 10.4 million deaths are because of hypertension. And when we see the population attributable risk of hypertension, 62% of strokes, 56% of chronic kidney disease are because of hypertension, 50% of heart failure is because of hypertension. Even in Africa now, hypertension is becoming dominant because of heart failure, as it was in even among the complications which we usually attribute it to hyperglycemia, 75% of disease and 30-40% of micro of hypertension. And when you see the global burden of hypertension, globally, up to 2010, there are about 1.9 billion people with hypertension. And of this, about 1 billion are in those with low-income countries, as compared to only 349 million in those with high-income countries, showing there is a BP shift from high-income to low-income countries. And as you see, this is a 2018 World Hypertension Day blood pressure measurement data, which is published in European Heart Journal. As we see, the prevalence of hypertension in Southern Africa is about 5%. The big is 7% in low-income countries are not on hypertensive medication. And of these hypertensive patients who are on medications, it's only 40%, which is 14, which is controlled. So the majority are not on antihypertensives. Of those who are antihypertensive, it is only a minority which is controlled. When you see the prevalence of hypertension in Ethiopia, these are the different studies in different regions. As you see, the prevalence of hypertension in Addis is about 30%. And there is the age category of this patient. As we see, this column is different. Some included above the age of 35, others above the age of 15, and the majority of them have excluded individuals except the one is done. So the prevalence in Ethiopia, according to this old studies, is from 50% and 30% in Addis. So meta-analysis of all these studies have shown the prevalence of hypertension and the prevalence of hypertension in rural areas is about 10 to 15%. And when you see the recent data, the 2015 STEP survey, which most of our staffs are involved, the prevalence of hypertension on that study is about 16%. And as you see, it is 16%. And the bad thing about these studies is they have excluded patients, elderly individuals above the age of 69. So the age range is 18 to 69. And as you see, it is only 40% of patients are aware of their high blood pressure. Of these who are aware, it is only a minority. As you see, it is about 10 to 15% which is treated. And it is only 1 in every 67 individuals with hypertension in Ethiopia are controlled, less than 140/90. So 1 in every 67 individuals with hypertension is controlled. So this is very low awareness, very low and also control. So what do you know about the risk of blood pressure in terms of cardiovascular disease? We know hypertension is a strong, independent, and consistent risk factor for cardiovascular event. And the risk begins as low as a blood pressure of 150 by 75. And then the risk increases for every 10 to 20 to 10 millimeter of mercury increase in blood pressure. There is doubling of the risk of cardiovascular event. And as we see, the risk increase is across all ages. Of course, it is modified by comorbidities and presence of other cardiovascular risk factors, but the risk of cardiovascular disease increases as both systolic and diastolic blood pressure increases. But despite the discovery of or the study showing increased risk of cardiovascular events with increasing blood pressure since 1928 because of the Society of Actuarian, so the Actuarian Society of America, hypertension has not been treated. This is blood pressure of President Roosevelt. As you see, in 1937, his blood pressure was 162 by 98, 1941 increased to 188 by 105. In 1944, after the D-Day, his blood pressure has increased to 100 by 100, and he developed pulmonary edema. By then, he has elevated proteinuria, but he was not on treatment. And his blood pressure progressively increased in 1945 to 260 by 155 after meeting the then Russian president in Yalta. And in a month's time, his blood pressure has increased to 300 and he died of cerebral hemorrhage. Because in 1940s, as we see, treatment of hypertension, there is no drug, and treatment of hypertension is basically for those patients with malignant hypertension, either through phlebotomy or other non-pharmacological methods. So by then in 1940s, a blood pressure of this range has been considered as having mild hypertension, and it was not recommended to start treatment. But so, as you see, as evidences accumulate, the definition of hypertension varies over time. As you see, the definition of hypertension.
Hello.
Yes. Yeah. Okay. The definition of hypertension varies. I think is okay. Hypertension. The definition has varied since 1967. As you see. Since the so the American Cardiology and the Society of you know, there is no single value that defines or identifies an increase in hypertension is defined as level of BP at which institution of therapy decreases cardiovascular events. So, as we live longer, we see the definition of hypertension change every time. So these have changed. Basically, in terms of there is no difference.
ቀረብ ብትል ስንታየው ወደ ማይኩ I don't interrupt ይሆናል።
Okay.
ቪዲዮውን ካንስል አድርጉት። ቪዲዮ ካንስል ሲደረግ ድምፁ ይጠራል።
አሁን ይሻላል ይሰማል አሁን
ይሰማል
Okay. So
ይሰማል
እሺ አንድ ባትሪውን ቼክ ማድረግ ፈልገን እሺ ቻርጅ ያደረገ ነው አሁን እንትን አድርገን
So, as I have already said, these numbers are the definition of hypertension, be it 130 by 80 or 140 by 90. They are just arbitrary numbers, and there is no single value after which there is a sudden increase in cardiovascular events. So, it is because of accumulation of evidences that the definition of hypertension changes over time. And so, any level of BP where institution of therapy will decrease cardiovascular event will define what hypertension is. And so before you go to the treatment initiation threshold and blood pressure target, I want to share some 2 to 3 slides on measurement of blood pressure. Measurement of blood pressure can be done in 2 settings, one in office and the other is out of office blood pressure measurement. In office, blood pressure measurement can be done with auscultatory, be it mercury sphygmomanometers or aneroid-based measurement. But now the preferred blood pressure measurement after the sprint trial is oscillometric or electronic or automated office blood pressure measurement. And the other way to do it with automated office blood pressure measurement is to make it unattended. It means you measure blood pressure in your absence at office after 3 to 5 minutes rest, and the physician or the health worker will leave the office and the patient alone, and blood pressure will 3 to 5 blood pressure measurement will be taken in the absence of a healthcare worker, and the average of the last BPs will be taken as office blood pressure measurement. This unattended out of office blood pressure measurement decreases White-Coat effect, and it decreases the usual office blood pressure measurement by 5 to 15 millimeter of mercury. So most of the recent studies use automated oscillometric blood pressure measurement, which is an attended one, but the sprint trial, which we will see later, used unattended out of office blood pressure measurement. The other way to measure blood pressure measurement is out of office, home BP or ambulatory one. And when you see the different studies, automated office blood pressure measurement, as you see it, automated office blood pressure measurement closely approximates ambulatory BP. As you see, the manual office blood pressure measurement is higher by 10 by 5 millimeter of mercury. So automated, it closely resembles either home BP or ambulatory BP, and it predicts target organ damage and cardiovascular events more as compared to the usual office blood pressure measurement. But for the residents, we need to measure blood pressure appropriately. According to a survey done in the US, 90% of physicians are not measuring BP appropriately. We need to have a quiet room. The patient should not smoke or take coffee, exercise for 30 minutes. Bladder has to be emptied. Patient should relax for 3 to 5 minutes. Back and foot should be supported. Foot should be flat on the surface. And we need to use, whenever we use validated, automated office, we need to use validated equipment. You have to visit Stride BP website and look whether that device is validated or not. Otherwise, it is not. And we have to use the arm cuff, not the wrist cuff, which is unreliable. The only thing is these automated devices are unreliable and not validated for patients with atrial fibrillation. If you don't follow these guidelines, as you see, if we usually measure blood pressure while we are taking history. So if patients are talking while we are measuring BP, blood pressure could increase by 10 by 15 millimeter of mercury. If an individual patient puts his legs crossed, BP could increase by 5 to 10 millimeter of mercury. And if back or feet is not supported, BP could increase by 5 to 15 millimeter of mercury. And if you measure blood pressure with over the close, BP could increase or decrease. And if you put the arms above the level of the heart, BP could increase by 10 millimeter of mercury. If it is below, it could decrease by 10 millimeter of mercury. So we may label an individual who is normotensive as hypertensive if you don't follow blood pressure measuring guidelines appropriately. And the other is out-of-office blood pressure measurement predicts target organ damage and identifies patients with white coat hypertension and masked hypertension. So in patients in whom we suspect white coat masked hypertension, these are patients with mild hypertension, patients with severe hypertension in the absence of end organ damage, or normal BP, office BP in the presence of target organ damage identifies masked hypertension. So in those circumstances, whenever we suspect masked hypertension and uncontrolled hypertension, we need to use either home BP monitoring or ambulatory BPs. And of course, we need to, after measuring blood pressure, we need to identify cardiovascular risk factors and also assess target organ damage, look for comorbidities, as 80% of hypertensive patients have one or more comorbidities. So it's only 15 to 20 which have hypertension alone. So we need to look for comorbidities which affects our threshold to start treatment and also our target to start treatment. And well, also in those with evidences, we need to look for secondary causes of hypertension. These are some of the lab routine and basic tests in patients with hypertension. So with this, I will go to our today's focus. As you all know, in the 1950s, after the discovery of hydralazine and reserpine, treatment of hypertension is basically for patients with malignant hypertension. So in the 1950s, treatment is only for malignant hypertension, but at the end of 1950s, 1959, the first study we showed benefit of hypertension in non-malignant hypertension, which is controlled but non-randomized, has shown a benefit. But the first study to show benefit of treatment of hypertension in non-malignant hypertension is the VA cooperative study, followed by HDFP, and then subsequently the Australian trial has showed a mortality benefit. So it is only after 1960s that non-malignant hypertension have been started on treatment. So when you see the benefit of treating hypertension, as we said, from observational studies, an increase in blood pressure is associated with an increased risk of cardiovascular result. A treatment induced reduction in blood pressure is associated with a decrease in cardiovascular event. So these are meta-analysis. Meta-analysis of 17 randomized controlled trials showed a 52% reduction in heart failure, 25% reduction in CV days, 40% reduction in stroke with treatment as compared to placebo. And now, does treatment of hypertension reduce all major cardiovascular events? This meta-analysis by Alberto Zaccarini and also Thomas have shown that all major cardiovascular events have decreased with treatment. Of course, the reduction in stroke and heart failure seems to be substantial as compared to other cardiovascular events, but all have decreased significantly. As you see, this absolute risk reduction here, as you see, all absolute risk reduction is substantial and significant for all major cardiovascular events, including all-cause mortality. And the other important thing is a reduction in major cardiovascular event is proportional to the reduction in blood pressure. As you see, if you are able to decrease systolic blood pressure by 20 millimeter of mercury, you can reduce the major cardiovascular event by 50%, 50. So 20 millimeter of mercury reduction reduces cardiovascular events by 50%. The same is true with diastolic blood pressure. The greater the reduction in cardiovascular events, the greater, the greater the reduction in diastolic blood pressure, the greater reduction in cardiovascular events. So what is the effect of blood pressure lowering treatment across the spectrum of the stages of cardiovascular, stages of hypertension? As you see, the relative risk reduction across the stages of hypertension, stage 1, stage 2, and stage 3. As you see, the benefit is across all stages. The relative risk reduction is the same for all stages of hypertension. So treating all stages of hypertension produces a significant effect. Of course, as we say, the greater reduction in blood pressure, the greater reduction in cardiovascular event. This is for a standardized blood pressure reduction of 10 by 5 millimeter of mercury. Otherwise, those patients with grade 2, grade 3 hypertension, they have a greater reduction in blood pressure with treatment, so it gives a greater reduction in cardiovascular event. So there is no doubt that since the VA study, treating grade 2, grade 3 hypertension has been established over the years, including in elderly, as it was seen in Sistero, so I will not be discussing on the evidences for grade 2, grade 3 hypertension, but let's specifically see benefit of hypertension in grade 1, treating in grade 1 hypertension. As you see, for grade 1 hypertension, is it treatment based on systolic blood pressure or risk-based treatment is better? These meta-analyses have shown that for patients with grade 1 hypertension, a risk-based initiation of treatment or denial of treatment is better as compared to a systolic-based treatment recommendation or differing of treatment, except in patients with prior cardiovascular disease. So with the exception of prior established cardiovascular disease, for patients with grade 1 hypertension, it is good to initiate treatment or defer treatment based on risk of individual. That is a total cardiovascular risk of an individual. And the BP treatment trialist collaboration meta-analysis have shown that in addition to the degree of systolic and diastolic blood pressure reduction, the higher the baseline cardiovascular risk of the patient, the higher the benefit from treatment. So those patients who are at high cardiovascular risk benefit most from treatment. And when you see the treatment benefit of patients who have grade 1 hypertension, that is based on the European 140 to 159, 80 to 89 diastolic, and who have a low to moderate cardiovascular risk, as you see, the risk of stroke, this is absolute risk reduction. These are relative risk reduction. As you see, all cardiovascular events have decreased significantly. And when you see the absolute reduction, as you see, the composite of stroke and cardiovascular disease decreases by 34%. It means if for every 1,000 patients treated for 5 years, you can avoid 34 major cardiovascular events. And the number needed to treat, as you see, it is 29. So even those patients with grade 1 hypertension with low to moderate cardiovascular risk benefits from treatment. And when we see the influence of cardiovascular risk on absolute benefit and the residual, the absolute residual reduction, the absolute residual risk, as you see, if you see this graph, this one, which is a composite of stroke, coronary heart disease, and heart failure, as you see, as the risk of cardiovascular disease, the total cardiovascular risk increases, the absolute benefit from treatment increases. But the big problem is total, treatment failure also increases. So in a patient who is at very high cardiovascular risk, whenever you start treatment, you get maximal benefit, but the residual risk is also significant. So now, the number needed to treat to prevent one cardiovascular event in a patient with low moderate risk is 152, whereas it is only 11 in those patients with very, very high risk. But the treatment failure or the residual risk in patients with high cardiovascular risk is high. So this is because of accumulation of target organ damage and cardiovascular risk and comorbidities over the years. So nowadays it is recommended to start treatment early in those patients with grade 1 hypertension with low to moderate risk. And what about those patients with optimal or normal BP or high normal BPs? That is a blood pressure between 130 by 39 systolic. So these are all the studies done in this group of patients. As you see, the baseline blood pressure, these are patients with normal BP or high normal based on the Europeans, or elevated and stage 1 hypertension based on the US guidelines. So these are studies on low, moderate risk and high risk studies. When you see the meta-analysis of these studies, those patients who are at very high risk benefits from treatment, even while they are in those pre-hypertension stage in the previous definitions, whereas those patients who are on high normal BP, who are at low to moderate risk, did not benefit. In fact, treatment is associated with worse outcome. So there is, from these all studies, there is evidence that those patients who are at high normal BP, who have a very high to very high cardiovascular risk, benefits from treatment. As you see, these are the absolute risk reduction. So treating those patients decreases stroke and coronary heart disease composite endpoint by 34%, and stroke alone by 27%. And in fact, all-cause mortality has decreased also significantly. You can see the p-values on this side. So there is, again, evidence for patients who are at high to very high cardiovascular risk to treat while they are on high normal BPs. And this is a HOPE-3 study, which is done in patients with low to intermediate risk patients, as you know, treating patients who are on grade 1 hypertension. This is greater than 143. Brings significant benefit, whereas treatment of patients who are in the pre-hypertension 131 and between 130 to 140 did not show any benefit. So the treatment of those patients who are high normal or pre-hypertension stages is only for patients who are high risk and very high risk one. The evidence are. So based on these all evidences, patients with grade 2, grade 3 hypertension has to be started straight away on treatment after we exclude, of course, white coat hypertension. And patients with grade 1, if they are at high or very high cardiovascular risk, they have to be started on drug treatment. For those patients low to moderate risk, the European Society of Cardiology recommends 3 to 6 months lifestyle change, but treatment has to be started as early as possible, because the earlier the treatment and the control, the earlier the benefit from cardiovascular reduction. So there is evidence to start treatment with low to moderate risk, but as you see, the number needed to treat is 152 to prevent one cardiovascular event. So because of that, the initial and because of cost-effective analysis, they recommend 3 to 6 months lifestyle intervention. And for patients with high normal BP, if they are established cardiovascular disease, they recommend treatment. They are, anyways, this group of patients are on treatment for the cardiovascular disease. But in the near future, there could be additional cardiovascular risk stratifying tool. This is a study published in 2020 in Circulation, presented in the AHA meeting. So as you see, this study is done by pooling participant level data from the 3 major US cohort studies, the ERIC, the MESA, and the Dallas Heart study. And they excluded from these groups patients with established cardiovascular disease, patients who have started already antihypertensives, they have excluded them. And they included 12,987 patients, and they measured their blood pressure according to guidelines with automated office blood pressure measurement. And as you see, these are the 54% of the patients have normal BP, and 27% of the patients have elevated BP or low risk stage 1 hypertension based on the Americans in whom there is no recommendation of treatment. And the others have qualified for treatment of hypertension and they have started on antihypertensives. And when they measure their biomarker, as you see, 36% of patients who have elevated BP, stage 1 hypertension, who are not recommended antihypertensive treatment based on the American guidelines, the current one, because their 10-year risk is less than 10%. 36% of them have one of either troponin or BNP elevation, 36% of them. And of those who have recommended treatment and started, 48% of them have 48% of them have elevation of one of the cardiac markers, that is NT-proBNP or troponin. As you see, those patients who are not recommended to receive treatment because of the current risk stratification tool, that is a pooled cohort study, because elevated BP, low risk stage 1 hypertension, whenever they have any of the biomarker positive, their 10-year risk of incident cardiovascular disease is 11%, as compared to those who have a negative cardiovascular risk, which is 4.6%, which is very close to a normal BP, that is 3.8%, 10-year risk of incident cardiovascular disease. So the number needed to treat patients with elevated BP who have negative cardiac biomarker is 86, whereas the number needed to treat to avoid one cardiovascular event over 10 years is 36 for those with a positive cardiac biomarker. And this is significant because if you take those patients who are recommended based on the current guidelines, that is 140/90 or 130/139, 10%, I mean 10-year risk greater than 10%, as we see, the number needed to treat is 49. So in the near future, probably a cardiac biomarker and NT-proBNP could be included in the risk stratification tool. Mind you, the level of elevation in cardiac biomarker in hypertensive patient is subtle and well below the cutoff point which we use for diagnosis of heart failure and acute coronary syndrome. Just they use 6 for high sensitivity troponin and 100 for NT-proBNP. So in the near future, for those patients with elevated BP and low risk stage 1 hypertension based on the American guidelines, the place of adding cardiac biomarkers could be there. So these are the group of patients. What is the target? So the target blood pressure, as you see, has been studied in the in the SPRINT trial in high risk patients above the age of 50. As you see, it decreases the risk of mortality by 25%. I mean, cardiovascular event by 25%, total mortality by 27%, by lowering systolic blood pressure less than 120. but the mean blood pressure in the group of patients is 121 as compared to 136. So there is a significant benefit with strict blood pressure control in the SPRINT study. And the benefit is for all, and it includes also patients greater than 75 years of age. 28% of the patients are here, and they benefit from treatment. And the big problem is the risk of adverse event is also significant. Hypotension, syncope, worsening of renal disease is also significant. And this study cannot be generalized to the general population because they have identified patients with fit patients, independent patients, and more than 90% of the patients are already on antihypertensive. And they used unattended automated office blood pressure, which is not used in other events. So it is very difficult to generalize. And they exclude also diabetics, those with significant proteinuria, patients with established cardiovascular disease, and so on. So just to see some slides on the benefits of treating, as you all know, benefits a 10/5 millimeter of mercury reduction in blood pressure from baseline of 154 in UKPDS reduces the risk of cardiovascular events significantly, MI by 21, stroke by 40, and so on. Also, the risk of microvascular complications decreased by 30 to 40%. And in fact, the benefit of tight blood BP control is significant or more than those which are achieved with tight glycemic control. And when you see the different studies, yes, lowering blood pressure to less than 140, there is a benefit because of HOPE study, the HOT study, I mean the advanced study, but in advanced studies, the benefit is minimal. As you see, it is only an 8% reduction with just lowering blood pressure less than 140 to 134. And in the STENO2 trial, lowering blood pressure to 132 by 73 reduces cardiovascular events significantly. But on the recent study, which is the SPRINT of the diabetes, that is ACCORD study, showed a strict BP control less than 120 decreases the risk of stroke by 41%. But other outcome did not decrease significantly, and there is an increased risk of adverse events. And recently in 2017, this is another study that is intensive versus standard BP control in the SPRINT eligible participants of the ACCORD trial. So they have identified individuals which qualify the SPRINT selection criteria from the ACCORD. It means they have excluded those patients with tight glycemic control. And it showed a significant benefit by lowering blood pressure to less than 130. That is, the mean is 120. And subgroup analysis of the ACCORD trial also showed lowering blood pressure less than 20 in diabetics whenever glycemic control is between 7 to 7.9%. decreases cardiovascular events. So those benefits of hypertension treatment, strict control in diabetic patients were offset by the tight glycemic control, that is hypoglycemia and others, which increases cardiovascular events. In diabetic CKD patients, lowering it to 120 by 29 in the IDNT trial showed a significant reduction in progression of kidney disease and a significant reduction in cardiovascular mortality. So how low should you go for all? This is a value trial. As you see, lowering blood pressure from 140 to 130 decreases all cardiovascular events. As you see, from 140 to 130, in all cardiovascular events have decreased. Whenever you decrease less than 130, the benefit of hypertension treatment in all cardiovascular events except stroke have flattened. So lowering blood pressure less than 130 decreases only the risk of a stroke. And with regards to diastolic blood pressure, as you see it, the lower is better, and lowering it to between 70 to 80 decreases the risk of all cardiovascular events significantly. Of course, the mean value is 75 millimeter of mercury. So, though the American Heart Association meta-analysis showed lowering blood pressure less than 130 by 80 decreases all these benefits, it is also associated with increased cardiovascular events. So we need to balance all, and we need to look for evidence of the lowest BP which should be attended. So is there any called a J-curve nowadays? Let us see some of the studies. This is a subgroup analysis from Clarify. As we see, the lowest risk of cardiovascular disease for all cardiovascular event, including all-cause disease, whenever systolic blood pressure is maintained between 120 to 129. And as you see, the lowest diastolic blood pressure, which is associated with the lowest risk of myocardial infarction is between 70 to 80. And of course, the lower the diastolic blood pressure, the lower the stroke, except whenever it is going less than 65. So when you see the INVEST study, which included diabetics with also coronary artery disease, as you see, the lowest risk of cardiovascular disease or myocardial infarction is between 70 to 80. And whenever it is going less than 70, the risk of cardiovascular event goes up again. And then when you see those with primary event and those without primary event, as you see, just those with primary event have BP less than or equal to 65 millimeter of mercury. So we need to maintain BP between 70 to 80 if possible. And we should not lower it less than 65. And when you see the lowest blood pressure, which is associated with the lowest cardiovascular event in patients with high cardiovascular risk without the presence of established coronary artery disease. This is subgroup analysis from On Target and Transcend. As you see it, those with blood pressure between 120 to 140 is the one which is associated with the lowest cardiovascular event. When you see the lowest diastolic blood pressure, which is associated with the lowest cardiovascular event, it is between 70 to 80 for all cardiovascular events. Of course, for patients with heart failure, it can go down a little. In elderly patients, yes, there are a lot of studies. Almost all of the studies done in the past are for those greater than BP of greater than 160 by 90. And as you see, patients above the age of 60, treatment of hypertension decreases all cardiovascular events. But in those patients above the age of 80, the reduction in cardiovascular event is limited to stroke and coronary events, and there is no reduction in all-cause mortality. And if you remember the recent publication of follow-up study of the SPRINT trial, the life expectancy extended by strict BP control is only 6 months for those individuals above the age of 80, as compared to 3 years for those who have started intensive treatment at around the age of 50 years. But we know from fever trial, those individuals above the age of 65, intensive treatment by lowering blood pressure less than 140 have shown a significant reduction in cardiovascular event, of course, more than the younger patients. What is the lowest blood pressure in elderly? Because low diastolic blood pressure is associated with increased cardiovascular event from population studies. But from subgroup analysis of the SHAPE study, lowering diastolic blood pressure less than 65 increases cardiovascular event. From the observational Rotterdam study, lowering again diastolic blood pressure less than 130, less than 65 diastolic, and is the nadir. The nadir is between 65 to 74 for elderly, and the nadir for systolic is 130 to 140. So we should not lower diastolic blood pressure in elderly less than 65 diastolic. These are the, as you all know, the goal of treating hypertension in CKD patients is to reduce cardiovascular events and mortality, and also reduce the progression of kidney disease. These are the 3 studies in non-diabetic CKD patients, MDRD, the ASC, and the RAIN2 trial. In all, lowering systolic blood pressure less than 130 by 80 did not show any reduction in progression of kidney disease. But subgroup analysis of the 2 studies, that is MDRD and the ASC trial, showed those patients who have proteinuria in the ASC study greater than 200 milligrams per day have benefited significantly from intensive therapy. So because of, and rather importantly, 28% of the patients in the SPRINT trial, that is 2,600 of the 9,000 patients, are CKD. So, and they benefit from strict BP control, but that is in terms of mortality and cardiovascular event reduction. It is not in terms of reduction in CKD progression. And in fact, strict BP control is associated with progression of CKDs, worsening of renal disease. So we need to balance both and follow and go. With regards to stroke patients, yes, meta-analysis and the SPS trial showed initiation of therapy in those patients with grade 1 hypertension, and lowering it to less than 130 reduces the risk of recurrent stroke by 43%. And but mainly this is driven by a reduction in ischemic, intracranial hemorrhage. So the recommendation is to lower blood pressure less than 170, all diastolic between 70 to 79 in all group of patients, and lowering it to 130, and if they tolerate it, go to up to 120, but blood pressure should not be lowered less than 120. There is no evidence of benefit to lower it less than 140. Just to look, so you can use one of the drugs. As I have said, meta-analysis have shown all the 3 drugs have no difference in terms of outcome, especially major cardiovascular events. In terms of individual outcomes, like heart failure is reduced more with thiazides as compared to calcium channel blockers, because this is mainly driven by ALHAT, where those patients with edema are counted as heart failure. But in terms of stroke reduction, calcium channel blockers seems to be better than the others. And in blacks, calcium channel blockers and thiazide seems to be better, but I want to emphasize that thiazide does not mean hydrochlorothiazide. And meta-analysis of studies comparing the thiazide-like and thiazide diuretic have shown that hydrochlorothiazide is inferior to indapamide and chlorthalidone, and in terms of blood pressure reduction with similar risk of metabolic side effects, and chlorthalidone and indapamide are associated with a superior coronary and all-cause mortality reduction as compared to thiazide. These are meta-analysis of indirect comparative trials. And as compared to other group of antihypertensives, hydrochlorothiazide as compared to calcium channel blockers, Addis and ACE inhibitor, it is found to be inferior in terms of reduction of the different cardiovascular events. So most of the previous HCT studies are either twice dosely or at high dose or in combination with other drugs. So if you have to use hydrochlorothiazide as monotherapy, you have to use it in those frail elderly individuals, or you have to use it twice a day. Beta blockers now have removed from as a first line guideline treatment because of as you see, as compared to placebo, beta blockers have never been found to decrease total mortality. And as compared to calcium channel blockers, the use of beta blocker is associated with increased total mortality and increased cardiovascular mortality. So especially in elderly above the age of 60, unless there is compelling indication, we should avoid it. But in young individuals where sympathetic overactivity is dominant, we can use it, or with concomitant indications. So I think with regards to combination therapy, previously increasing the initial dose of monotherapy substitutions and so on are used, but monotherapy substitution or increase the initial dose should be used only in low risk grade 1 hypertension patients and those elderly individuals who are frail, we are afraid of initiating combination therapy. We can use monotherapy substitution because each of the antihypertensive is effective in controlling BP in 30 to 50% of grade 1 hypertensions. If they don't respond, substitute it to a second drug, 70% of patients will respond. And if they don't respond, if you go to the third drug, 80 to 89 will respond. So this is only for low risk grade 1 elderly individuals who are frail to start combinations. The combination initiation is associated with freedom from side effect, and you get maximal effect. As you know, the maximal reduction in blood pressure achieved with antihypertensive drug is with half the standard dose. So going from half standard to full dose and double the standard dose gives only a minimal reduction in blood pressure. So this is a study by comparing doubling of the standard dose and going the combination of two drugs at low dose. As you see, a combination of the two drugs at low dose, at half standard dose is associated with a significant reduction in blood pressure. And the other important thing is the side effect of antihypertensives is almost equivalent to a placebo at half standard dose. So combining drugs at half standard dose decreases blood pressure significantly in the absence of side effects. And the other thing is initial combination therapy reduces cardiovascular events. Which combination should you use? These are the studies with the combination treatment. So far, a combination of a RAS blocker with a calcium channel blocker have been found to be superior as compared to etiazide plus RAS blocker. And this is an accomplished trial. It is associated with a 20% reduction in all primary outcome, a 21% reduction in cardiovascular mortality, and a 48% reduction in risk of CKD with RAS blocker plus amlodipine as compared to HCT plus RAS blocker. And in fact, especially in thin individuals, lean individuals, this benefit is pronounced, and it is associated with a 38% reduction in cardiovascular deaths, 40% stroke, 50% heart failure. So especially in lean individuals, we have to go for RAS blocker plus calcium channel blocker. But recently in 2020, an African study, the Creole trial, has been published and showed amlodipine HCT is equivalent to amlodipine perindopril in Black individuals. It is done in sub-Saharan Africa, but this is in terms of 24-hour blood pressure control. It was not assessed on hard clinical endpoints. And for those individuals with resistant hypertension uncontrolled, after we exclude pseudo hypertension, we need to go for aldosterone antagonists, which have been shown to decrease blood pressure. This is a pathway trial. We showed spironolactone is superior to bisoprolol plus doxazocine in terms of blood pressure reduction. And this has been, again, true for CKD patients in other studies. And if potassium is less than 4.5, GFR is greater than 45, you have to go for spironolactone and monitor those parameters. If this is not the case, we have to check heart rate and go for either beta blocker or an alpha blocker. Just to say one or two slides on BP variability. BP could vary over 24-hour and over long term. And this variability is associated with increased cardiovascular event, increased target organ damage, and increased mortality. And these variables in blood pressure affects outcome. And if you see short-term BP variability, as you see, morning hypertension or an early morning BP surge is associated with increased target organ damage and increased stroke. As you all know, the risk of sudden death, MI, stroke, all cardiovascular events tends to cluster in the early morning. This is because of morning hypertension and a rapid rise in blood pressure early in the morning. The other thing is nocturnal hypertension. Average blood pressure during sleep is associated with increased target organ damage and cardiovascular risk as compared to normal one. And even in the absence of awake hypertension, nocturnal hypertension is associated with increased cardiovascular event. And absence of dipping and rise in blood pressure at night is associated with increased risk of cardiovascular event, even in the absence of nocturnal hypertension. So if both are present, the nocturnal hypertension and absence of dipping are present, the risk of cardiovascular event is significant. So for a perfect blood pressure control, we need to have perfect 24-hour blood pressure. We need to have a perfect nocturnal dipping, and we need to avoid blood pressure variability, and we need to avoid an early morning BP surge. And for this, calcium channel blockers, amlodipine has been shown to lower blood pressure variability and risk of stroke as compared to all the antihypertensives. So using amlodipine as a backbone can avoid blood pressure variability and decrease stroke risk. And the other way to do it is moving one of the antihypertensives. This is a diabetic hypertensive study. Moving one or more of the antihypertensive to bedtime as compared to giving all at awakening reduces cardiovascular event by 67%. Mind you, this is for a similar awake blood pressure, 127, 1.7. Just lowering asleep blood pressure reduces this cardiovascular event. This has been also seen in the HIGA trial, which is associated with a 45% reduction in cardiovascular event. And also in the MAPEC trial, we showed that benefit. The last slide, this is patient's blood pressure could vary over a season. So blood pressure is higher during the winter, the season. During the cold season, it gets higher, and it gets low during the summer season. So an individual who come from abroad during a summer season there, if they arrive here as a winter, BP could vary or vice versa. So we need to follow blood pressure, and for those with symptomatic hypotension, we need to adjust the drug based on the season if they have symptomatic hypotension. Thank you, but don't forget to look for non-pharmacologic treatments and the focus on prevention of disease, as the salt intake in our country is very high and obesity is getting high. We need to work on. Thank you.
Okay, thank you, Dr. Sintayehu, for the excellent presentation. Since we are 20 minutes past 9, we will not have enough time for questions. Those who have questions can ask or communicate to Dr. Sintayehu directly. I will allow only 2 comments, one from Dr. Dejuma first, and then Dr. Bekale. Yeah, thank you.
Thank you, Dr. Sintayehu. It was a very nice summary of all important issues in hypertension. I don't have much comment, but well, with regard to which guideline we follow, especially in classifying hypertension, the national guideline still uses the European Society of Hypertension guideline, which classifies hypertension into 3, grade 1, grade 2, grade 3. So we still use a definition of 140/90. So this is important to note. Though there is a benefit of lowering blood pressure to a level less than 140/90, as from public health aspect of view, if you first concentrate on those blood pressure above 140 by 90 and have a good control, which was shown to be very poor in our country, would be the first priority in our country. So we need to use that guideline until revision comes. And this is a comment that I have, and other points are already been touched. Thank you.
Thank you very much, Sintayehu. It's always a pleasure to be contributing at least a little to your career, because things are becoming more and more marvelous. That's what I have. With regards to hypertension, my worry generally in hypertension is when we look at the studies, most of the studies, they did not have targets. The studies that had targets consistently were like the former studies, like the SHEP trial, the CIST-EURO trial, and subsequently HIVET, COT. Those studies had cut points, but studies like ADVANCE, On Target, HOPE, HOPE3, you know, they were just considering BP lowerings. There were no targets. But both of them have shown reduction of cardiovascular mortality, or cardiovascular endpoints were reduced by both sides. Now, the ones which have gone to lower targets in concrete terms are ACCORD and the SPRINT trial. The ACCORD probably suffered generally from the lower event rates, because you know those diabetic patients are you know being dealt with statins and other things which definitely reduce cardiovascular endpoints, and probably the assumption is, you know, those event rates were low to generate a difference between the two sides. But the SPRINT has conclusively come down to say that the lower target is better, but this group of patients were clearly very high-risk patients. Now the issue is it really targeting that cardiovascular endpoints, cardiovascular risk is the most important issue, or the BP reduction? That is an important matter. Why? Because studies like the HOPE trial, without due consideration of even the blood pressure, they have shown, you know, reduced mortality in high risk and cardiovascular patients without LV dysfunction and other things. And they use AC inhibitor in that study. So now, when we target such low blood pressure in high risk patients, which was very clear with the SPRINT trial, should we use RAS inhibitors, or do we really, because in the West, hypertension treatment is very much skewed towards RAS inhibitors. So are these benefits limited to those drugs and limited to the increased cardiovascular mortality? And I mean, the cardiovascular risk as opposed to the BP reduction? I think in my mind, this remains always a question. Otherwise, you know, probably the benefit might be limited if we use drugs like thiazides and calcium channel blockers in such low blood pressures. Do they have strictly the same benefit similar to the benefits we obtained with the HOPE trial in high-risk individuals? I think that needs to have an answer. Otherwise, things are becoming clearer and clearer. This is the comment I have.
Thank you.
And Sintayehu, you can respond. You can respond if you have. I mean,
no,
any
I have
clear,
nothing.
Yeah.
Thank you, everyone, for your time. Thank you.
Thank you. Thank you.
Yeah. Thank you very much.
Thank you. It's a very nice presentation.